alaikum warahmatullahi wabarakatuh. Hello, Journey Club listeners. Today we'll be talking about epicomarginal defects. We may encounter these cases that are prognostically challenging, those with severe endoperial lesions with vertical bone loss characterized by localized bone loss along the root's entire length, often on the buccal side, and this characteristic can be mistaken and misdiagnosed for vertical root fracture. A recent case series by Baruwa and colleagues published at the JOE 2023 on the management of epicomarginal defects with endodontic microsurgery and guided tissue regeneration. The study evaluated 13 teeth with epicomarginal defects treated using epicoectomy combined with guided tissue regeneration, specifically bone grafts, including both xenografts under the brand name BioOs of bovine origin, and autologous grafts that are harvested from the patients themselves and collagen membrane barriers, with a follow-up period of up to 9 years. All cases were performed in a private practice by the same endodontist in Portugal between 2011 and 2015. Cases were severe. They were classified as KIMS Class F, which is the worst type. That means they had a full buccal bone loss and a communication between the root apex with the marginal periodontium, typically with poor prognosis. Each case underwent epicoectomy and a retrograde filling using MTA. All received BioGuide, which is the brand name of a collagen membranes. Some received BioOs alone. Others received the BioOs mixed with autologous bone that is harvested during the surgery from the adjacent cortical plate. The rationale behind choosing the BioOs alone in some cases, specifically 4 cases out of the 13, versus combining it with autologous bone in the rest, was based on 2 factors. The first factor was the size and the configuration of the defect. The larger or deeper defects with more extensive buccal bone loss used a mixture of BioOs and autologous bone, while smaller contained defects have been managed using BioOs alone. The second factor is the bone availability. If a sufficient autologous cortical bone was found based on the operator judgment and can be easily harvested from the surgical site, it was harvested and used. All cases received collagen membranes, and the healing was evaluated based on Rademov's criteria. Clinically, no symptoms, no problem defects, no sinus tracts, and radiographically a complete resolution or a reduction in periapical radiolucency. For the results, 11 out of the 13 cases showed complete clinical and radiographic healing, an 85% success rate, and 2 cases, which accounts for 15%, had partial radiographic healing and were symptoms-free. And no cases showed vertical root fractures, despite the initial suspicion. Compared to earlier reports of low success rates ranging from 27 to 44, these outcomes are considered impressive, and it is aligning with a previous study in 2003, which used xenograft, the BioOs, with a collagen membrane and reported 83% success, which aligns with the current study. What caught my attention in this paper is the concept of inducing bleeding to support the healing in the bony crypt. The surgical site was intentionally curated to stimulate bleeding and promote blood clot formation, which is crucial for early healing and graft stabilization. They described this procedure clinically after completion of the epicoectomy and the MTA filling, and all the granulation tissue was removed. The surgical bony crypt was curated again to obtain a blood clot, and this recurettage step serves in many purposes. It promotes clot formation and creates an early fibrin scaffold. It improves the graft integration and improves the graft and membrane adaptation, which supports the angiogenesis and the osteoprogenitor cell migration. Another interesting point in the study was the autologous graft technique they used, which they harvested the patient's own bone collected from the cortical bone by using a bone scraper to gently collect the shavings or chips from the adjacent buccal cortex, with advantages of avoiding a second surgical site, for example the mandibular ramus or symphysis, and to provide a regenerative osteogenic potential. For the study limitations, the amount of bone that was harvested was not quantified, and that preoperative CBCT was unfortunately not used in all cases in the study, and the healing evaluation was based on 2D imaging. There were no quantification of the lesion size and the evidence strength. This paper is a case series. There is no control group or statistical analysis. However, it is the most recent available evidence about epicomarginal defects and their management. This paper shows the potential of combining endodontic microsurgery with guided tissue regeneration, which has been shown to effectively stimulate the periodontal tissue healing in cases of epicomarginal defects. These approaches can lead to favorable long-term outcomes and demonstrate promising results in improving the prognosis of teeth affected by such defects. And I believe that this study is a great example of how modern endodontics can save teeth that used to be considered hopeless. And thank you so much for listening. Hope you have a wonderful day. Bye.